please stay tuned to the end of this program or see the show notes for important information regarding today's speakers and the content of this podcast. Hey everyone, welcome to episode 3 of Allergy Watch, a roundup of the latest in the field of allergy and immunology by the American College of Allergy, Asthma, and Immunology. For today's episode, we'll be reviewing 3 articles about food allergy from the May-June 2019 issue of Allergy Watch. Allergy Watch is a bi-monthly publication which provides research summaries to college members from the major journals in allergy and immunology. To subscribe to Allergy Watch, head over to the college website at college.acai.org/publications/allergywatch. This is part 2, a review of the May-June 2019 issue of Allergy Watch. My name is Jerry Lee. I'm an assistant professor at Emory University, and I am an assistant editor for Allergy Watch. And as always, I'm joined by my co-host, Marion Kalangara.
Hi, this is Marion Kalangara. I'm an assistant professor of allergy and immunology at Emory University.
And our rotating chair, once again, is joined by the editor-in-chief of Allergy Watch and a past president of the college, Stan Fineman.
Hi, it's great to be here. I'm also an adjunct faculty at Emory, so I'm pleased to be here too. Thanks.
And critical part of the allergy immunology training program. I would say you are definitely the third leg of the stool if it's pediatric, medicine, and community. And clearly, Stan Fineman has certainly done a lot. As I'm the program director for the fellowship, by the way, so I have to state how important Stan is for our training program. So I think we were going to focus on food allergy testing and evaluation. So I think, Stan, you had a very interesting study about new testing methods for food allergy.
Okay, so the first article we'll discuss was presented by David Kahn. The headline is, "Can BAT eliminate the need for milk challenges?" And he is citing an article by Runnemans Kurtz, I may be mispronouncing it, in the Clinical Experimental Allergy Journal that was this past year. And the title of the article is "The Basophil Activation Test Reduces the Need for a Food Challenge Test in Children Suspected of IgE-Mediated Cow's Milk Allergy." So a little bit about the background, of course. The only way we really have to confirm a diagnosis of a food allergy is a double-blind, placebo-controlled food challenge. And, it's cumbersome, it's difficult. We really are not doing double-blind food challenges in our office clinically. We do them as part of research studies. But, right now we do a lot of the food challenges, open label. But it's still very cumbersome, and we're always concerned about the risk for anaphylaxis. And so you have to be careful who you choose. And the basophil activation test has been a relatively new option on the research level, at least for food allergy. And in fact, about a year or two ago, or maybe several years ago now, there were some articles by Gideon Lack, who was looking at BAT for peanut allergy. So this has been done before. It's still not mainstream. We don't have it available for clinical use, but this was a study looking at cow's milk allergy. So this was a prospective study looking at 86 children who had suspected cow's milk allergy by their history, and the researchers felt these were candidates for the double-blind, placebo-controlled food challenge. Interestingly, 90% of the children did undergo a food challenge, and specific IgE measurement, and the BAT was performed using a particular technique, and they used a dry powder cow's milk extract that did contain the 3 major antigens or allergens in cow's milk, which includes casein, alpha-lactalbumin, and beta-lactoglobulin. So the analysis really included the total of the 97 BAT tests. 9 children had the test twice. And then the double-blind placebo-controlled food challenge was positive in 18 of the 36 IgE-sensitized patients, compared to 5 of the 61 non-IgE-sensitized patients. The results with both the double-blind placebo-controlled food challenges and the BAT were unequivocal in 80% of the cases, and the BAT was 100% sensitive and specific in the IgE sensitized patients, which is very unusual for a lab study. So in contrast, all but 5 of the 50 non-IgE sensitized children with unequivocal results had negative findings on both the double-blind placebo-controlled and the BAT. So these patients generally had mild responses to cow's milk, typically associated with a non-IgE mediated reaction. A lot of them had tummy aches. And these patients had relatively mild responses, as we said. So in children who are clinically suspected of having cow's milk allergy, who have a positive specific IgE, the BAT can be helpful as a diagnostic, because of its 100% sensitivity and specificity in these patients, as opposed to the even the double-blind placebo-controlled challenge, which is sometimes equivocal, and the kids sometimes had a few mild symptoms that were probably non-IgE mediated. And then David Kahn's comment, of course, was that the researchers found that the remarkable 100% specificity, 100% sensitivity for the BAT in the milk-sensitized patients with a history of milk allergy is really unique, and that data, should be interpreted with caution because there were only 36 patients who actually had the milk-specific IgE. Some of the children sort of had inconclusive tests, and maybe some of them, the basophil test might not have been that, evaluated. But obviously we need larger studies, we need commercial availability, and, so it's an interesting test. It does, the BAT does look specifically for anaphylaxis, and I know it's been used in peanut allergy, as I said, but, we look forward to having it as an option for our food allergy patients.
So I will be the first to admit that I had no idea we were even using BAT for food allergy. But it's interesting, and if it does indeed eliminate the need for positive challenges, I think it could potentially have a high degree of utility in our clinics. I've been using BAT mostly for the evaluation of perioperative drug allergy specifically. I use it in conjunction with skin testing to neuromuscular blocking agents using non-irritating concentrations, just to sort of corroborate skin test results and help sort of outline my recommendations to use alternative agents.
Yeah, it would be great to have a test that could, predict anaphylaxis, so we don't have to put our patients at potential risk.
So, the Dave's comment suggests that sometimes the test is not available or maybe inconclusive. How often do you run into that problem when you're evaluating drug allergy?
Right. I noted that in this study specifically, I think there were 13% who were non-responders. So to be honest, I ordered these tests pretty infrequently, and I haven't run into that issue yet. In fact, I didn't even know that was a problem with it.
Oh, okay. Yeah. I mean, again, I think I've never ordered this test, so it's very good to hear your perspective, Maren, and certainly, we're always looking for that holy grail. We've been, people. That's why people are so fixated on, cutoffs and rules of thumb. We really, really would love to have this magical number. This is what we're supposed to do. If it's, we should challenge for this number, we should avoid for this number. But, all the time we're seeing so many patients where, especially with a great history, the test could have steered you the wrong way if you use some rule of thumb. But a lot of these patients can definitely tolerate the food, and so having a test that doesn't run into those problems is highly desirable for sure.
Yeah, we're all struggling with the patient who is, quote, sensitized,
yes,
but not clinically, not clinically reactive to the food.
Right. I mean, and my experience with drug allergy has been that so far they've used BAT for several different medications. They've used it for proton pump inhibitors, some antibiotics, neuromuscular blocking agents. The sensitivity is supposed to be lower than the specificity. And I haven't had any positive test results yet. But if it indeed were positive, then it would be extremely useful in outlining recommendations. So.
Good.
Oh, that again, thank you for that. That's a great article, Stan. So, Maren, sounds like we're switching gears to the relationship between food allergy and eczema.
Right. So I chose to review a paper by Epen et al. That was published earlier this year in Annals and reviewed by Dr. Hernandez Trujillo in Allergy Watch that highlights the risk of food avoidance in patients with atopic dermatitis. And we often see this where children with atopic dermatitis end up on these highly restrictive diets that exclude foods that they've either never eaten or once tolerated and are now avoiding because of positive IgE testing, despite the recognition that there is really no high-quality evidence to support these elimination diets in atopic dermatitis. Parents often end up doing this because of concern for food-triggered disease. However, there have been several recent reports describing an increased risk in acute allergic reactions to foods following elimination for prolonged periods to help control possible food-triggered eczema that had been previously consumed without incidence. And of note, in these reports, there was no improvement in eczema symptoms following food elimination. And this particular study sort of adds to this evidence and examined the frequency of failed in-office challenges to foods that had been similarly consumed uneventfully prior to elimination to treat possible food-triggered eczema based on a positive skin test or in vitro testing. The authors did a retrospective analysis of 442 challenges to the top 5 allergenic foods over the course of about 6 years and studied outcomes among children with atopic derm among whom food was eliminated to treat their eczema. And this was compared with failure rates of challenges in children with IgE-mediated food allergy and also those who were sensitized without prior introduction. Nearly 3/4 of the challenges were done because of a history of food allergy and only 10% for this food-triggered atopic derm. The overall failure rate of challenges was about 20%, and the failure rate for those avoiding a food because of atopic dermatitis was 13%. This was not significantly different from those avoiding food because of other reasons. And again, there was no difference in the duration of avoidance in the atopic dermatitis group between those who passed challenges and those who failed, and the median was about 2 years in both groups. Tolerance to these foods specifically was lost after the food had been withdrawn from the diet and then not reintroduced onto the food challenge. The authors did note that one of their drawbacks was the IgE criteria used in offering food challenges, and there has been recent data from a separate report showing that the IgE levels that strongly predict food allergy in patients with severe dermatitis are well above the commonly used 95% positive predictive value thresholds. And thus, children may have been excluded who could have passed the food challenge and altering overall results. What I thought was really interesting was that the authors found that this loss of tolerance happened as early as 3 months after withdrawal of a food item for this reason. And for this reason, they suggested close monitoring and reassessment of the skin within 4 weeks of implementing these dietary changes. And they also suggest that patients with food-triggered atopic derm warrant an emergency action plan and self-injectable epinephrine. I thought there were several take-home messages in this paper, the big one being that a clear risk factor for developing immediate reactions in atopic dermatitis is the avoidance of culprit foods. And importantly, this can happen as soon as within 3 months of elimination. And especially taken in conjunction with evidence for a decreasing role for diet in propagating atopic dermatitis, we must carefully consider whether strict elimination is even necessary. Another option that has been proposed by other authors is to keep a tolerable amount of the food trigger in the diet, since the risks of immediate reactions on reintroduction may outweigh the value of elimination in atopic dermatitis management. Another thing that struck me was that we really need better predictive value of allergen-specific IgE tests in patients with eczema that can more effectively discriminate whether the patient is allergic or not. Or maybe we can even start doing basophil activation testing in this population. Since these decision points maybe much higher than those that apply to a less atopic population. But the bottom line is that we should probably be more aggressive about offering food challenges in patients with atopic dermatitis and these elevated serum IgE levels. I'm sure you both agree with.
We struggle with these patients. I mean, I just saw one yesterday. A young infant came in with atopic dermatitis. Mom was limiting, egg, milk, all kinds of things in the diet because it showed up on a immunicap that was done by the pediatrician. Mm-hmm. And the question is, what do we do with these patients? I mean, it's a real challenge. I wish we had better tools, to tell them, is it a true allergy or not?
And, I think when we take that step further, this is a very common referral we get from the pediatrician. And, when I do in-services to pediatricians, we're just doing a meet and greet, hey, refer to us, that sort of thing. This comes up a lot. And, really when the patient is asking for food allergy testing, I think what the patient is really asking for, or the parents, is why is this happening to my child? Mm-hmm. They want an explanation of where did this rash come from. And so really all the information that we've learned recently about the role of skin barrier function as the cause of eczema is sort of the key piece of information that could potentially head that off at the pass. So at least in some of my messaging, and I'm not saying I'm always successful, is that redirecting the family to answer the primary question, why is this happening, right? Which is skin barrier dysfunction. And then I would say number two, most family members by now have been enough blogs or Google or so on to learn about the impact of the LEAP study. At least if they're not familiar with it, they could quickly Google it after leave my office, right? And if you sort of clearly demonstrate the benefit of keeping in the diet and the potential of using medical therapy to allow your child to be protected from food allergy and to have a full diverse diet and not be restricted, some parents do buy into that. But, obviously it's close follow-up, it's explanations, but clearly empowering more pediatricians to have those initial conversations of teaching about the origins of eczema and the importance of medical therapy to allow your child to have a full diverse diet and side effect wise preventing food allergy. This is sort of something I've been very interested in. We have the college has an existing atopic dermatitis quality improvement module for allergists. And so right now we're exploring, can we deliver that same educational module to primary care pediatricians, because it's quite a simple module, but also include some of the messaging and education. So stay tuned. I think we're talking to the ABP to get that approved, but that's something I'd love to see to empower pediatricians to sort of not reach for that food allergy panel as their first thing, but this is the initial intervention.
Right.
That'd be great.
So,
and I agree with Jerry. You see the same parallel in adults with chronic hives, where they're
why is this happening?
Mm-hmm, why is this happening? And always searching for a food cause. So. Yeah,
and so that internal. It's not the fact that hives can be an internally driven versus externally driven is, is sort of a gap and sometimes hard to convince, but over time I think you develop a relationship with someone and just introduce them to a concept they've not considered. Sometimes is enough. Good. Sometimes we need a test. You're right.
Good article.
Oh no, it's a wonderful article. Okay, so. I have the last article that we're going to review. This is from one of the most sort of well-known, prestigious allergist, Donald Leong. And again, it's a privilege to sort of see his work over time and his contributions to, JACI, now the annuals, and sort of elevating our specialty. So this was published in Science and Translational Medicine this year, and the title of the article is "The Non-Lesional Skin Surface distinguishes atopic dermatitis with food allergy as a unique endotype. So, we've now talked about the relationship between eczema and food allergy. The dual exposure hypothesis states that existing eczema is a setup for the development of food allergy, and therefore identifying what biomarkers or endotype of the skin that leads patients to develop food allergy would help us intervene even early before we're doing early food introduction. Because, we know that certain studies have shown that egg sensitization can occur even before they even started solids, I remember the Palmer study that showed that, about 33% of the patients had to drop out of the study even at age 4 months because they were already allergic to egg. So clearly we need sort of ways to identify patients even earlier than that. And since we can't get all patients with eczema, what are some ways to do it early, but also non-invasively? So because, skin biopsy is not going to be an option for infants. Parents are not going to have their newborn baby biopsy to assess for this. So the non-invasive method that the Lyon group decided to use is this repetitive tape stripping method. So essentially what that means is that by repetitive sort of application of tape and removal, you can collect samples of the skin in a very non-invasive fashion and do assessments for different metrics. You can measure transepidermal water loss. You can look at skin proteins in the skins. You can do metabolomics. You can look for infections. So looking at a wide library of variables, what drops out when we're trying to distinguish of the patients with eczema who will develop food allergy and who will not. And so what they did was they got non-lesional skin from atopic dermatitis children who both had food allergy versus patients who did not, and also completely non-atopic children. And what they found, as you can imagine, is that even the non-lesional skin, we're talking about the skin that has no evidence of rash, did have evidence of increased transepidermal water loss compared to patients with atopic dermatitis, but not food allergy, and also the non-atopic children. Those food allergic children also had decreased filaggrin, which we know is a key protein and key risk factor for food allergy, and a low proportion of omega hydroxyfattic acid sphingosine ceramide content, as well as changes in the stratum corneum lamellar bilayer structure responsible for barrier homeostasis. Now, they also looked at other markers, so they did see increased abundance of Staph aureus and specific keratin expression increases. Keratins 5, 14, and 6 were particularly identified, and that sort of indicates hyperproliferative keratinocytes. They also looked at the transcriptome, and so they see this sort of gene profile that increases the expressions of genes of dendritic cells and the type 2 pathways. And so if they do a network analysis, they find that keratins 5, 14, and 6, like I mentioned before, is positively correlated with food allergy, as well as the identification of certain filaggrin Brecken products would be negatively associated with food allergy. So now that we have sort of an idea of what the endotype profile of children with AD who develop food allergy versus the ones who don't, can we use that information and develop a way that we can identify children at risk very early and then potentially do an even earlier intervention so that we can protect more children before they even come and see the pediatrician asking the food allergy question. So before we even get the chance to do early food introduction. This is so exciting that we're able to get a lot more information, and this study gets me, looking forward to future sort of publications from this group to see if we can refine this assay in a way that we can make an impact on the food allergy beyond what we've already done earlier and earlier.
Oh, yeah, that's really interesting. And actually, it ties in very nicely with this recent longitudinal study that's actually still in press in JACI that talks about the presence of Staph aureus colonization in patients with atopic dermatitis and the predisposition between this colonization and food allergy to peanut or egg allergy, and this is independent of the severity of atopic dermatitis at baseline. So it's an interesting thought as to whether, I guess, looking at sort of baseline factors could sort of help to predict and possibly undertake like preemptive measures to prevent.
Yeah, I thought it was very clever to do this skin stripping to get the sample, and the fact that the even in non-lesional skin, they detected problems, which that's really not on our on our radar screen. We usually tell them to put the moisturizers, especially where the lesions are, but we probably need to tell them all over.
Oh, yeah.
Yeah, I mean, the abnormalities in non-lesional skin and atopic dermatitis have been, were described a few years ago by the dermatologists. And I think so both abnormalities in non-lesional skin as well as subclinical inflammation in previously affected areas after sort of superficial resolution of the inflammation. So I usually tell my patients to not just continue the topical steroids until resolution, but rather continue it for a few days after to address that possible like subclinical inflammation, and also use sort of proactive intermittent therapy for those patients with severe disease to address, again, subclinical inflammation.
Yeah, and so, as we sort of gain more knowledge about this relationship between risk factors for food allergy, and again, the better treatment, the more understanding about eczema and how to treat it, my biggest curiosity is, as we figure out the best interventions to treat eczema and potentially prevent food allergy, perhaps, that big waiting list we have for food challenges right now, my hope is, that'd be something I'll tell a story about, sort of in the twilight of my career. That's sort of, and again, it just gets me really excited. So, anyways, that's the end of the episode. Once again, I really want to thank Maren and Stan for preparing the articles and giving their expert commentary. Also want to thank the college for sponsoring this format to provide education and again promote discussions amongst allergists. Now, we're still very new. This is a new venture, so please send us your feedback. The email address again is allergytalk@acaai.org. The ACAAI is presenting this podcast for educational purposes only. It is not medical advice or intended to replace the judgment of a licensed physician. The college is not responsible for any claims related to the procedures, professionals, products, or methods discussed in the podcast, and it does not approve or endorse any products, professionals, services, or methods that might be referenced. Today's speakers have the following disclosures. Dr. Lee was on an advisory board for Teva. Dr. Kalangara has received consulting fees from AstraZeneca, and Dr. Fineman has been a speaker for AZBI, Shire, and has done research for Aimmune, DBV, Shire, and Regeneron.